Hello, my name is Jeff Taylor, and I'm at the 25th CROI here in Boston with Dr. Pablo Tebas.
Hi, Jeff. How are you?
Welcome. How are you?
Fine.
So it's the last day of CROI, and there's been a lot of interesting data being presented this year on the cure, which is happening every year, and it's kind of building up momentum, and there's a lot of interesting things. So what stood out for you at the conference so far?
Well, it's becoming, 25 years is a long time, and it's becoming more mature in many ways.
Right. Well, 25 years ago, we didn't dare talk about the cure, right?
And I think, overall, the conference has been very good, as usual. I think the most interesting and the data that is going to change practice is in TB, but I didn't attend those conferences. I went mainly to the lectures surrounding the cure, strategies for the cure. And I think there has been very interesting data presented. Still, we don't have the cure, obviously. But if we think about the strategies that we are thinking that are required to eradicate infection, if we focus on the kick, trying to reactivate the virus from the latent reservoir.
So part of the kick and kill strategy.
It was a mixed bag. So there was a clinical trial looking from the ACTG, looking at 5315, a single dose of romidepsin, several doses, to see if that will activate the HIV reservoir. There was a publication from I think a Danish group that showed that you can wake up the HIV virus to start expressing proteins, even to replicate, because they were able to detect viremia. And that's required to allow the immune system to target the reservoir. So they didn't confirm that. And that was a little bit of a bummer because we had a lot of hope in romidepsin, and I don't think it's going to be the latency reversing agent. But there was a lot of data in vitro, and the poster session was phenomenal. So there was a group looking at TLR9 as a booster of the CD8 immunity against HIV. There was a very interesting poster clinical trial, phase 1. I couldn't believe it was not an oral, from the Minnesota group looking at a superagonist of IL-15 superagonist that really seems to activate the HIV from latency. And the dose was low, but it looked safe. So, it was only 9. Team Checker. Very nice data. Then there is a Chinese study looking at blocking interferon as an activator of the reservoir. We know that interferon has antiviral activity. If you block the interferon, the HIV seems to activate. So there is a lot of presentations in the poster sessions that look at different ways to kick the reservoir, and I think we have several leads. There was another drug that, some of those interferon blockers are used in therapeutics, so they have been in humans. So it's not a big leap of faith that we are going to start doing trials looking at some of these latency reversing agents. That's in the kick. There was a very interesting presentation too in the kick. This is a monkey study that was done by the Harvard group here.
Dan
Baruch, looking at TLR7 agonists. So what they did is they took 44 monkeys, they infected them acutely, and treated them with antiretrovirals relatively quickly, 1 week. 44 monkeys, 4 groups. One, they did nothing. Another group, they give a broadly neutralizing antibody called PGT121. The other group, they gave the TLR7 agonist, and the last group, they gave both. This was given when the monkeys were suppressed with antiretrovirals, and then they stopped the antiretrovirals a while after the last dose of the antibody. Some of them, the TLR7 and agonist and the antibodies were given at the same time. And half of the monkeys controlled the virus. And they tried to look for HIV, not in the way one would think, but they took cells from those monkeys and infected other monkeys, and they were unable to infect the monkeys. So it seemed that those monkeys have cleared the infection. It's very promising. The TLR7 is in humans, has been in humans, and the antibodies start becoming available. So it's a monkey study. Monkeys are not humans, but it's the first time they tilted the study towards success because these were acutely infected monkeys treated very, very, very early. So reservoir is small, but as Paula Cannon used to say, you only need to cure one person to prove that you can do it.
Right.
So
Timothy Ray Brown, right?
Yeah. So So I think that was very promising. So a lot of promise in this on this strategy.
So with that monkey study that Dan Baruch did, do they have any clue as to why half responded and half didn't?
Well, no, they are looking at explanations for that. They think there is a boosting of the CD8 responses there. They didn't present, or I didn't see a lot of that about what it was the effect on the reservoir, because I think that was the hypothesis that by giving the TLR7, the cells that are infected with HIV start expressing protein, and the antibody is eliminating them by ADCC. But I have to relook at the presentation to see if I can stop in some of the slides to look at the data that supports that there was a decrease in the size of the reservoir. But it was very interesting, and I think we will hear more in the future about that type of strategy. More things about the cure. I think the reservoir matters, and there is a presentation this morning from the CTG, also the neuro study, looking at reservoirs in the CSF and linking them to neurocognitive function. The association is not that strong, but it's an association, so we might need to start worried about the CNS reservoir, although I don't know how relevant it's going to be, but we have to look at it. We have been sort of ignoring it.
Well, both for the cure and for clinical reasons as well, right? It can be associated with neurocognitive
dysfunction, and then it's not easy to sample. I mean, I don't know how good a LP and a CSF is a surrogate of what's going inside the brain, the tissue, but it's not a procedure that is simple.
Well, I know there's some autopsy studies that are being done to start looking at that. UCSD is doing something called Last Gift in terminally ill patients, where they do rapid autopsies so they can get really good samples to examine
I was
that.
not aware of that data. Good. And what else? I mean, so that's in kicking. In targeting more boosting the immune system, not a lot of data on new vaccines against HIV or anything like that. There was some presentations about broadly neutralizing antibodies, but I think the combination of broadly neutralizing antibodies have not been presented in this meeting. I think the group of New York is looking at using combo antibodies and probably publishing it directly. I know the study is almost done. So, and this is more on a strategy for a functional cure. So it's giving the antibodies and stopping antiretroviral therapy and see if the combo of the antibodies can maintain viral suppression, which seems like is my work. So.
And then anything interesting in gene therapy?
I have not seen any clinical trials presented here about gene therapy. We are at our group in the University of Pennsylvania at Delaney. We're going to be opening a CAR T cell trial. So,
you want to explain briefly what CAR T cells are and how they work?
So the problem of vaccines with HIV is that it's a little bit of a not directed process. You don't know what is going to be when you vaccine somebody. You don't know exactly how it's going to be the immune response, but you can engineer the immune response. So what a CAR T cell is a cell that has a T cell receptor. The CAR is a chimeric antigen receptor. So what it does is it defines the specificity of the cell. So by selecting what is outside the CAR, that molecule, you say this T cell, this CD8 cell or the CD4 cell is going to go for this specific antigen. So they are being designed to treat leukemias, for example, very successfully, and they were approved recently. 2 months ago, the FDA approved, I think more, 4 or 5 months ago, they approved the first CAR T cell therapy for leukemia. So what they did in that study was to this receptor recognized a protein that is only expressed in B cells. So they target all the leukemic cells and they eliminate them. They are incredibly efficient. So the CAR, what we want to do is to put a molecule outside that will target HIV infected cells. And we have decided to use CD4 because it has been in humans. 15 years ago, people did the study with the old generation of CAR T cells in HIV patients, and the patients 10 years later are doing fine. But now there has been
Was that the Sangamo trial you were referring to?
No. This was Carl June in 2003. CD4 is CD4 zeta.
Okay.
So they did this, and the cells have survived for more than 12 years. But now we have much better signaling inside the cell. So now we know how to make these cells proliferate, be more active, survive. So we're designing these CAR T cells, and we're going to be opening the study in the fall. But they have to be combined with a latency reversing agent. And we don't have a good latency reversing agent right now, because in order for these CAR T cells to find HIV infected cells, they have to be expressing protein.
Right.
If they are
you have to wake
latent,
them up first.
yeah, they are latent, they are not going to find them. So that's why it's so exciting to see all these new approaches to try to reactivate the reservoir. Because the answer is going to be a combination of 2 or 3 things to target the reservoir.
Combination therapy, just like we did for treatment, right? So.
Yeah, it's going to be different for cure, but it's different combination, but definitely is an exploding field. And I mean, it's remarkable the advances that are being done in the very basic science. And I think we will start seeing more phase 1, phase 2 studies in the near future. There were good things about antiretrovirals. I mean, bictegravir was recently approved. There were a couple of switch studies presented that bictegravir looks pretty much like dolutegravir. There is a lot of excitement in antiretroviral treatment because of the intermittent therapy with the injectables and the broadly neutralizing antibodies.
And also dual therapy, right? They're moving from 2 to 3 drugs in some.
From 2 to 3, from 3 to 2 is there is accumulating data that you can maintain suppression with 2 drugs. So the idea that you can induce with more aggressive regimen and then step down to 2 is becoming more commonplace than it used to be. We knew that you can do it with protease inhibitors and 3TC. I think now with dolutegravir 3TC, the body of evidence is there. We need to wait for some of the trials that are being done by ViiV, like the Gemini and Tango, to show that that's it. And to show also that you don't pay a price by doing that, like more inflammation or more. I mean, if you're virally suppressed with 2 drugs, it makes sense that to do that.
Yeah. Viral suppression is viral suppression, right?
Viral suppression is viral suppression. I don't know how tiny changes on levels of inflammation. I don't know how clinically relevant they are, but statistically for sure. But we'll see. We'll see what happens. It will lower the cost of taking care of patients with HIV because, of course, you will go from 3 to 2 drugs, and one of them is generic. I mean, 3TC is generic right now. It will affect the care because of patients because the U.S. HIV care is so crazy. I mean, a lot of the clinics depend on 340B funding. So you have this perverse situation that if you use cheaper drugs, you get less support for your clinic.
Right.
It's completely insane, but I mean, that's the American health system for you.
Yeah.
And it's very different if you're in public insurance or you're in private insurance.
Right.
So, of course, if you're in a private insurance, the insurer would like to lower the price of the cost to make more money and to provide care for more people.
Right.
But if you're in public insurance, the cost of the drugs subsidize the care.
Exactly.
It's just a perverse system. And for foreigners, it's so difficult to understand.
It's difficult for Americans to understand it. No one.
It's very difficult to understand how it was created and why we're in the situation we are.
All the more reason for a cure, right?
Well, yeah, I mean, we should cure people. There is a lot of stigma about HIV still. And for patients living with HIV, it's very important that they feel that at least there is the possibility of a cure.
Exactly.
The good news is that people are living longer, they are healthier, they are taking 1 pill a day many times. These pills are much better tolerated than the old ones. There is much less side effects. And in general, the HIV population is doing well. Yeah. At least in the developed countries, if you have access to care. If you don't have access to care, it's messy. Here,
which is true
in
even
Africa,
in this country, yeah.
Yeah, everywhere it can be complicated. But I think overall, there has been a lot of improvements, and I hope in the next few years we work really on the cure and to try to eradicate HIV. the first step is going to be this therapy every 3 months or something like that. And
Yeah,
then,
it's going to be incremental.
And then it was going to be incremental, and then we will get to...
So you're thinking it's going to be a functional cure that will, over time, get better and better and last longer and longer?
Yeah, I mean, we need some fundamental advances of identifying what is the reservoir, which that was a negative, not so positive. I mean, there was a lot of excitement a few months ago about this marker for the reservoir, CD32A. Was a paper in Science, and everybody, oh, this is great. Now we know what cells to target, because now, but it turns out that 4 of the 5 different groups have proven that it's not the reservoir, or it's not what they thought it was. It's not a latent reservoir. It's probably cells that are replicated to some levels. There was also several posters about the safety of treatment interruptions, which I think they were very encouraging. When you
So in the context of a cure trial, you have to interrupt
therapy to prove that that the virus doesn't rebound. Treatment interaction trials have been a little bit disappointed because everybody rebounds, but there is no other way to test the effectiveness of an intervention. So there was questions about the safety of treatment interruptions. Of course, it's not safe proof because you're allowing the virus to come back. But there was a lot of concerns in the past about receding of the reservoir, that by stopping therapy, you're going to lose all the benefits that you had, even in acute infection. There were 4 or 5 studies, and the findings are very consistent. When you stop therapy and you become viremic for a few weeks, and you restart therapy, 6 months after you restart therapy, you're where you were 6 months before. So it tells you 2 things. One, that the reservoir is incredibly stable, which is difficult to understand why, but that's something that we need to figure out. And the other thing is that by doing these brief analytical treatment interruptions, you really don't pay a huge price on the size or the composition. There was very nice studies, Katie Barr had one, looking at changes in the reservoir. So the virus that rebounds is not enriching the reservoir. So the reservoir, when you resuppress after a treatment interruption, is not coming from the virus that went
it's the same
out.
reservoir that was there before.
It was the same reservoir that was before. And that is reassuring, is that we don't understand how the reservoir is completely established. Why is this constant number? Although we know that there are clones of cells that go up and down. There was a nice presentation about that over time. But it remains unbelievably stable. 1 cell per million PBMCs. And why? I mean, that's pretty amazing. That is so tiny and so fixed. Is something that it mesmerized me. So, I mean, it's interesting, and I think there has been advances. And next year, I think we will hear more. And hopefully we will start seeing trials with interventions that have a signal.
When, as you say, now we can do them safely, and patients can enter those trials knowing they won't pay a clinical cost.
Not a huge clinical cost. I mean, there's always a risk, because when you stop, there is inflammation. I'm not going to try to minimize that there is a risk. But in the setting of a well-monitored treatment interruption, I think there is a risk that for people that want to contribute to finding a cure for this terrible disease is reasonable. It's not, I have a 50% chance of something catastrophic happening to me.
Exactly.
No, it's not that. And it's a small risk, and for people, it's not for everybody, but for people that want to contribute to the cure, I think it's a reasonable risk. And I don't feel, of course, when you do these trials, you're worried as an investigator. I'm putting my patients at risk for this. And you obviously don't want to do that because you care about your patients, but the risk is reasonable.
Well, as you mentioned, I mean, in the community, there's so much desire for a cure that people are willing, just like in the early days of treatment, that people are willing to take those risks because they believe the outcome.
Yeah, the community drove the advances on antiretroviral therapy at the beginning of the epidemic, and I think the community will drive the advances for HIV cure. So we count on you guys.
And you. It's a team effort. Well, thank you so much, Dr. Tebas.
Thank you.
Appreciate it. Enjoy the rest of your conference.
Thank you.